This is the recording that accompanies Chapter 13 material. We are beginning the last section of our class, which is 3 chapters, as has always been the case from the beginning of the class. This 3-chapter section covers 13, 14, and 15 with various treatments for different mental health conditions. As you can tell from this title slide, we're going to start with depressive disorders and bipolar disorder. And then the second group is about anxiety disorders, treatments for anxiety disorders. And the third group is treatments for schizophrenia and other psychotic conditions. Okay, so a slight change from what we had been doing. However, I've given you the heads up that toward the end of the course, this is what we're going to be transitioning to, is talking about pharmaceutical drugs intended for treating diagnosable mental health conditions. So I'm not going to assume that everybody's had a background in mental health conditions. You probably have some familiarity, but without taking a full course in abnormal or something like that, you may not have everything you need. So I will teach what you need to know about the drug treatment perspective, and probably not teach it as thoroughly as you would get from an abnormal class. But I want to make sure everybody at least has the basics they need to understand the medical treatment of mental health disorders. And then we're going to focus on depression initially, and then we'll transition to talk about bipolar disorder, and we'll talk about some of the pharmacogenetic factors that we're starting to gain some understanding about, so that we better understand why some people respond more favorably to antidepressant medications and some people do not respond very favorably at all. So a mental disorder is a impairment that comes from somebody not being able to behave the way that they would have expected to, think the way that they would expect to, or have normal emotional functioning. And the prevalence of mental health disorders are widely prevalent by estimates. We don't have a diagnosis for all these people, but the World Health Organization estimates that 450 million people would qualify for a mental health disorder diagnosis if they, saw somebody to get that coverage and they receive the care. So what we're saying is that probably a lot of mental health disorders are undiagnosed, untreated, an unfortunate instance because they do present some impairment in the person's functioning. All right, so starting with depression, and what you see in front of you is a list of the various symptoms that are possible. So the first two are really key symptoms. You need at least one of the two, and most people with depression probably have both, that they feel bad, and the depressed mood is the first hallmark symptom, and then lacking an interest in pleasure in activities that they normally got pleasure from or were interested in. Now, the remaining symptoms after that are things that could be there, but you don't need all of them to be there for a diagnosis of depression. So somebody could be changing in their body weight, which means they could be gaining, they could be losing, but any appreciable change in body weight could be part of depression. Same thing with sleep. They could be sleeping more, they could be sleeping less, they could be sleeping the right amount, and yet it's disturbed sleep and they're not sleeping very well. They could be fatigued, they could be feeling worthless, they could have difficulties in thinking or concentrating, and they could have thoughts of death, which usually mean they're thinking about suicide, is what we're focusing on there as a potential symptom of depression. So from that list I just showed you, to be diagnosed with major depressive disorder, you need to have at least 5 of the symptoms from that list that persist over a period of 2 weeks or longer, and that qualifies you for a diagnosis of major depressive disorder, or MDD. The second disorder in this screen is dysthymic disorder. Now that's kind of an old term. Your book still uses it, but these days that term is being replaced with persistent depressive disorder, and that would get the abbreviation PDD. So the persistent is really the difference there. So you're looking at a difference between major depressive disorder and persistent. So with persistent, and dysthymia is the same thing, it's just they're changing terms. The depressed mood that the person has to last for at least 2 years rather than at least 2 weeks. And that's where the term persistent really makes a lot of sense, because it's persisting across a long period of time. Now, probably the symptoms are going to be less severe in persistent depressive disorder or dysthymia, because frankly, if your symptoms are lasting at least 2 years, you've included the at least 2 weeks period in the 2 years. But for the person to be diagnosed with persistent depressive disorder rather than major depressive disorder, the symptoms are probably going to be less severe for persistent depressive disorder. And then we're going to tack on a major depression with psychotic features, where the person has the symptoms of depression, but they also have hallucinations and delusions as part of their depressed mood. Depression is the fourth leading cause of disability worldwide, and that's saying a lot because we've got predominantly medical cause of disability above that. So as a mental health condition, is contributing a lot to people's disability. It really affects people's lives when they have either persistent depressive disorder or major depression or depression with psychotic features. Across an entire lifetime, the prevalence of major depressive disorder is 16%. And when you look at different age groups, a lot of people have thought, well, maybe it's younger people that have depression more, maybe it's older people. Really, it's fairly balanced, and I've got a slide to depict some of that. So we have adult depression depicted here, since we start with a young adult category of 18 to 29, then we have 30 to 44, 45 to 59, and greater than 60. So that 16% that I cited is somewhere in here, and that's averaging across all these lines. There does seem to be a slightly interesting trend that older people seem to have maybe less diagnosable depression than younger people, and that could be because they've sort of come to grips with things and they don't feel as depressed anymore. There's been several explanations that have been offered for that apparent drop in depression, but also the overarching conclusion that depression is probably fairly similar across our lifetime is probably the better conclusion to make. So when you do brain imaging of somebody who has a diagnosable depression, you see some brain structure differences. So you'll see some differences in the amygdala. Amygdala being a threat detector could be triggered differently in people who have depression. The prefrontal cortex, which is where you do some of your higher order thinking, and that could be thrown off, and you can understand why that depression might affect a person's higher order thinking. The hippocampus, which affects a person's ability to form memories, or maybe their memories are forming differently and maybe causing somebody with depression to be plagued by memories that trouble them and give them depression. And then here's one old area that we've been talking about throughout the class of nucleus accumbens. Maybe they're just not getting the proper rewards from normal lifetime activities in the midbrain area. We've been talking about it being something triggered by drugs, but in somebody who is depressed, maybe the nucleus accumbens just isn't giving them that natural feeling that things are okay, and that's going to lead them to a sense of depression. Shifting away from just understanding depression to the drug treatment of depression, we've had drug treatment for depression back to the 1950s. When we think about the drugs that remain available today, we're looking at MAO inhibitors, and that comes from monoamine oxidase. That's the MAO inhibitors. MAO is an enzyme. It's a monoamine oxidase, and what it does is it breaks down any of the monoamines, and we'll talk about what the monoamines are and how they're used in the treatment of depression. But if we inhibit that enzyme from breaking them down, it's going to keep more of the monoamine neurotransmitters available. So the things we're talking about here are things like dopamine, norepinephrine, serotonin, would all be elevated because we're going to decrease the breakdown of those neurotransmitters. Tricyclic antidepressants, the tricyclic part of this term comes from the chemical structure. There's 3 cycles in the chemical structure. That's probably all you need to know where that name comes from. We'll talk about the specific properties of tricyclics in just a bit. There's selective serotonin reuptake inhibitors, and these are more commonly known by the abbreviation SSRIs. So you may have heard that abbreviation, and that's where that abbreviation comes from. We'll talk about those. SNRIs, the next group. So this is serotonin norepinephrine reuptake inhibitors. So what we're seeing here is a modification of the original SSRIs to include norepinephrine reuptake inhibition as well. So we're implicating other neurotransmitters as well. And then finally, a class of atypical antidepressants drugs. They don't have the properties of these, or these, because they work differently, and we'll talk about some atypical antidepressants. So MAO inhibitors, because they were found to work, actually created the monoamine hypothesis of depression. People started to believe that the reason why people were depressed is there were underlying deficiencies in monoamine neurotransmitters in their brains, and that was what's causing the mood. So most of the drugs after MAO inhibitors have followed that lead and have focused on the monoamines and tried to increase their rates through various mechanisms. Table 13.1 is a good summary that provides you the 5 different classes of antidepressant drugs that I just introduced you to with some examples. I'll just quickly look through this and tell you which are the ones that are probably most likely to be come across. Nardil, Parnate, and probably just those two. Nardil and Parnate are probably the two more commonly used MAO eyes. For tricyclics, probably tofranil, Elavil, and enafranil are probably the most common in that list. Here in the SSRIs, oh geez, it's almost all of them. I would say that they're probably all fairly well used. Maybe Prilogy is a little bit less used, and Upstein maybe a little bit less used, but all the others are very common. For the SNRIs, both Cymbalta and Effexor, not only will you hear them, you'll probably see numerous commercials and ads for those drugs. They're really sort of marketed heavily these days. And then on to the atypical antidepressants, you got Wellbutrin and you got Remeron are probably the two most common ones. All right, so we're going to go through each of the categories of drugs, starting with the MAO inhibitors. And I already mentioned in introduction what the MAO inhibitors are going to prevent the breakdown of any of the monoamine neurotransmitters. Included in that list, we're going to see serotonin, dopamine, norepinephrine. So you have both irreversible MAO inhibitors and reversible. Reversible are a little bit more mild and a little bit less impactful because you can actually undo those effects. They're more temporary because they're effective while they're bound to the MAO, and when the drug is being metabolized out of your system, then you get some relief from the MAO inhibitions. But the irreversible ones are pretty much producing their effect, and you can't really undo that effect until, like I said, that drug is totally metabolized out of your system. One of the complicating factors for MAO inhibitors is the cheese reaction. So people have to monitor their diets when they're taking MAO inhibitors. So the drug itself, it could lead to a buildup of tyramine. So tyramine is actually it was on this list, but I skipped it because I wanted to cover it in context of this cheese reaction. Tyramine is a dietary enzyme that is part of a lot of dairy products. Milk, cheese, many other dairy products will have tyramine in it. And what the MAO inhibition causes with tyramine is a buildup of tyramine within your system, and it causes side effects. So the person could have an increased heart rate, they can have hypertension, they can start sweating, they can have inhibited digestion. So the person has to avoid eating those kind of dairy-based foods because if they don't, they're going to have a interaction between the MAO inhibitors that they're taking and the dairy products that they're eating, which could become dangerous side effects. So it's complicated, and it's not an easy drug to manage because of the need to monitor dietary intake, specifically of dairy products. So the newer MAO inhibitors don't have as much of an issue with the cheese reactant. They're more selective in terms of targeting specific receptors. So here we're talking about MAO-B enzymes and not as much inhibition of the MAO-A enzymes. And then a reversible inhibitor of MAO called abbreviated REMA is going to also cause more selective effects, which is going to be helpful in minimizing that cheese reaction. All right, moving away from the MAOIs, we're going to go to the tricyclics. So tricyclics work somewhat differently. They're blocking reuptake of norepinephrine and serotonin, and they're also going to antagonize other receptors as well. So by blocking the reuptake, you're going to get higher levels of serotonin and norepinephrine, but you're not going to have the side effect of the cheese reaction. You're not going to have to monitor dietary intake, specifically of dairy foods. There are other side effects with tricyclics, so we're not totally in the clear with lacking side effects. So dryness, dry mouth, dry eyes, drying out your digestive system to the point you become constipated, and keeping your urine, so urinary retention. So that's happening as a side effect of these drugs. You can also have some dangerous cardiovascular effects. You can have some sedative effects with tricyclics. You can have weight gain. You can have type 2 diabetes. So like I was saying, we're not clear of side effects here. We have to be aware that there's some serious potential side effects going on with tricyclic antidepressant use, which is why we've been developing other drugs since the MAOIs and the tricyclics have been developed previously. One of those major advancements in antidepressant medications has been and continues to be the SSRIs, the selective serotonin reuptake inhibitors. So what these drugs are going to do is they're going to block the reuptake of serotonin, increase the amount of serotonin. Now, you should remember, and this section gives me a good chance to review, that serotonin is generally thought to be as a feel-good neurotransmitter, and having the person have more serotonin in the body should make them feel good or better than they were before, so that they don't have to experience the debilitating symptoms of depression. Probably the most common of these SSRIs, Prozac, fluoxetine is the generic drug name. Certainly safer compared to MAOs and tricyclics, and because of that, it's probably one of the most widely prescribed drugs in our history. However, SSRIs are not without their problematic side effects. So you can have a serotonin syndrome where the person becomes agitated, restless, has cognitive impairments, hallucinate. They could have discontinuation syndrome where if they stop taking the SSRIs abruptly, they could have sensory problems, they can have sleeping problems, they can lose their balance, they can have flu-like symptoms, gastrointestinal effects. So like I said, we've got some issues with SSRIs as well. However, compared to tricyclics and compared to MAOIs, SSRIs are safer. SNRIs are going to do a similar mechanism to what I just talked about with SSRIs, but instead of just focusing on serotonin, you're going to see a blocking of the reuptake of norepinephrine as well, and you're going to have higher levels of serotonin and norepinephrine as a result. So SNRIs are a little bit better than SSRIs. I didn't mention the sexual side effects, but there are some sexual side effects that go along with SSRI use, and because people don't want their sexuality to be affected, SNRIs can be preferred. And there are a number of patients that don't respond to SSRIs, so having another alternative like SNRIs is going to be helpful to reach more patients with antidepressant drug treatment. Atypical antidepressants are going to be grouped into this class because they either don't have a chemical structure or they don't have a mechanism of action that matches the other categories I already introduced. Probably the best example of a drug in this category is Wellbutrin, generic name bupropion, and bupropion or Wellbutrin effectively blocks the reuptake of norepinephrine and dopamine, a combination, like I said, because atypical we hadn't seen before. So some of the things we have to think about when using antidepressant medications is a somewhat lengthy response time. So you're going to see the first clinically significant effects after 2 weeks of treatment, and the full effects of the drug will take about 4 weeks of treatment. And for somebody who's depressed, that could be a long time because, for 2 to 4 weeks, they're still fairly depressed waiting for the drug effects to kick in. Other problems with antidepressant drugs is treatment resistance. So when people have tried multiple categories of drugs and they're still not getting effective symptom relief from their depression, that they're considered treatment resistant, and that qualifies for 29 to 46% of patients are going to fall in that category, which means we need some other alternative. There's also some issues with antidepressant drugs needing to go through clinical trials, as most drugs do, but the hard part about a clinical trial for depression and an antidepressant drug is that the base of comparison for the antidepressant drug is a placebo. So many times when people are in placebo-controlled clinical trials, they're going to show strong placebo effects, which means that the drug has to be way up and above the strong placebo effects that you find, which can be a hard hurdle, and many drugs will not meet that hurdle and not be approved because of the strong placebo effects that we sometimes see on treating a mental health condition like depression. One of the things that has been beneficial from learning how drugs treat depression is that we've been able to use the impact of knowing how the drug works first, and then understanding how it relieves depression, understand what types of symptoms are relieved with the drugs, and then what other types of symptoms we might need to focus on differently with other kinds of drugs. So that's certainly been helpful throughout the sort of learning pathways of learning more about drug treatment for depression. One of the common features that I hope you grasp, but I'm making sure you did as I summarize these antidepressant drugs, is most antidepressant drugs are going to have some effect on raising serotonin levels in the brain. And another common feature is increasing dopamine concentrations in the prefrontal cortex, so making the prefrontal cortex more active and making the person simply feel better with higher serotonin levels. Okay, so transitioning away from the depressive disorders to bipolar disorder. So one of the features that comes with bipolar disorder is that you have depressive symptoms as part of the bipolar disorder, but the other pole, since clearly there's two poles with bipolar, is manic experience. So mania consists of abnormally elevated, irritated mood, arousal, high energy. Person could talk fast. They can have rapidly changing ideas going through their head. They can engage in impulsive decision making. Poorly thought out decisions, lack of ability to concentrate, all that stuff is part of manic behavior. So the person will alternate between those two patterns. Table 13.2 from your book is a summary of what I just said with the mood and behavioral changes. And then you have two different major bipolar disorders. You have a type 1 and a type 2. Type 1 is the classic variation between depressive experience and manic experience. Now, the duration to meet diagnostic criteria for type 1 bipolar disorder is the depression needs to meet criteria for major depression, so at least a 2-week period of depressive symptoms. And the manic phase of type 1 bipolar has to last for at least a week of manic symptoms that meet the diagnostic criteria. Now, there is a fallback diagnosis of type 2 bipolar, and that is there for people who don't meet either the duration or severity of symptoms for either the depressive phase or the manic phase. But it's still clear that they're cycling between depressive phases and manic phases, but the symptoms may not be as severe for a type 1 diagnosis, or they may not last as long as they need to for a type 1 diagnosis. The most common thing that people miss when presented with bipolar disorder is diagnosing as depression, because they see the person in a depressive phase and they either don't get good enough information from the person or they fail to ask. Frankly, it could go either way. Does the person experience other periods in their life when they're not depressed and they're maybe appearing bipolar? The big problem with misdiagnosing bipolar disorder as depression is if you use depressive disorder treatments on bipolar, you tend to make the bipolar worse. So you want to make sure that when you're treating, you're actually properly treating for depression, or you know it's bipolar and then you properly treat for bipolar. Bipolar disorder is far less common than major depression or persistent depression. We know from some of the brain impacts of the disorder that there seems to be some differences in terms of where the mania is coming from. Mania in the right hemisphere tends to be more prevalent. Depressive effects seem to be related to the left hemisphere. Why, we don't know, but it's just sort of observational stuff. For people that have bipolar, the basal ganglia and thalamus tends to be larger. And then there's also this thing called unidentified bright objects, UBOs. Those are higher areas of excessive activity in certain parts of the cortex, of white matter specifically. And once again, we don't know why that is. It's just one of the things that we find when we image people's brains that are diagnosed with bipolar disorder. So one of the original approaches with bipolar disorder is to try to just stabilize the person's mood, not let them have such dramatic highs when they go to mania, not have them such dramatic lows when they go to depressive phase. So try to keep the highs and lows from varying as much as they would normally, and that's what a mood stabilizer drug could do. Unfortunately, most mood stabilizer drugs don't equally affect both the depressive and manic symptoms. Frankly, most mood stabilizer drugs are more effective at managing the manic side of the disorder and less effective at the depressive side. I'll have more comments about that because we've gotten better with more modern drugs. But we also know that beyond mood stabilization attempts at drug treatment for bipolar, we also have some effect from anticonvulsant drugs and antipsychotic drugs. So lithium is sort of your prototypical mood stabilizing drug. It was first discovered in 1949, and as I said, lithium as a prototypical mood stabilizer drug is going to be more effective for mania than for depression. But lithium has serious adverse side effects. So the person could be caused to experience nausea, vomiting, diarrhea, and it's even more complicated because of what's called a narrow therapeutic index. So when you try to get a person who has bipolar and experiencing symptoms under control, you aim for this category of the therapeutic effects in the acute range. And you generally need the blood concentrations to fall in the 0.8 to 1.6 range. Now, once the person is effectively treated and stabilized, you can back down to this level of drug in their blood. And then the issue with this is, even though you need the person in this range to get the bipolar symptoms to be resolved, they can start to get adverse effects right here, very close to where the therapeutic effects are. And the drug can be lethal right up here. So this is really complicated too, because what it might take to get the person to receive effective treatment relief of their symptoms, you're very close to the lethal level. So, and you got somebody who's diagnosed with bipolar who's taking these drugs in the first place. So you're putting a dangerous drug in the hands of people who's got some issues with impulse control, have some issues with depression, could be suicidal. Not a terribly safe drug is what I want you to hear there. Lithium has a large variety of actions, so it produces some things in second messengers, it could affect gene expression, it could protect some things in your brain, and it could impact this GSK3 enzyme, which is a protein kinase that promotes apoptosis, a term you may not know, but apoptosis is cell death. So the enzyme itself promotes cell death, and if we inhibit it, we're going to keep more cells alive. And also, it plays a role in regulating inflammation. So it does a lot of different things, and it's not one thing specifically that lithium does to treat. It's not a simple mechanism of action, is what I want you to know about that. Now, shifting away from mood stabilization drugs to anticonvulsant drugs, we've found that some antidepressant drugs are likely to produce beneficial effects on the symptoms of bipolar. It may not just be because they affect GABA, which is largely what anticonvulsant drugs do. So GABA is our body's main inhibitory neurotransmitter, and having GABA be stimulated by these drugs makes some sense because we're just going to decrease the activation of the brain. But there's also some decreasing of sodium channel functioning, which may have an impact on manic symptoms. There's also an effect similar to what I just told you with the lithium of inhibiting that same GSK3 activity, and that may have some beneficial effect because we know that it does for lithium, and it may also drift over because anticonvulsant drugs affect GSK3 in the same way that lithium does. That may also be producing some beneficial effect on managing bipolar symptoms. And then lastly, the atypical antipsychotics are actually safer and now have become more first choice or first line treatments in treating bipolar because they're just safer. And while lithium remains a viable option, you're going to probably try these atypical antipsychotic drugs first. One of the things that you may not be surprised to see is that when somebody is given an atypical antipsychotic, they may also be given an antidepressant along with it, and that combination treatment is something that's becoming more common. Okay, the last stuff I'm going to cover here, and there's like 1, 2, or 3 slides to cover, I forget exactly how many, but we're starting to learn that antidepressant drugs specifically may affect people differently because of differences down at the genetic level. So there may be genetic differences that alter a antidepressant's drug ability to cross the blood-brain barrier, and that can help to explain treatment resistance because if it's not crossing the blood-brain barrier, it's not going to have the same effects. And the example is down here of a specific genetic polymorphism, a genetic subtype of people that would have issues in responding to antidepressant medications because those drugs aren't going to cross their blood-brain barrier as effectively. There are some pharmacogenetic information suggesting that at a genetic level there may be differences in our ability to transport serotonin, and there may also be genetic differences in neurotrophins, which are brain chemicals that are going to interact with the antidepressant medications that we're using, and they could adversely affect the medications that we're using. So those are things that we're starting to become more aware of as we're starting to realize the impact of genetics on the use of antidepressants and the likelihood of effective symptom relief with some genetic subtypes and interacting with the antidepressant medications. All right, that was my last slide, so I'm going to go ahead and end the recording here and my coverage of Chapter 13. Next time, we're going to cover the treatments for anxiety disorders.